there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some useful tips which may prove handy in your line of duty. Welcome to part 80 of our pharmacotherapy MCQ series, which majors in basic oncology. And the first question reads, which of the medications listed below is or are recommended by the NCCN guidelines for the maintenance therapy in squamous cell non-small cell lung cancer, what we call NSCLC patients? Is it docetaxel? Is it pembrolizumab? Is it gemcitabine? Or are all of the above correct? I'll give you 10 seconds to choose the correct answer. So all of them are recommended. I would like to start by saying that maintenance therapy refers to systemic therapy which may be administered after 4 to 6 cycles of the first chemotherapy to advanced NSCLC patients who have responded to their previous treatment or have stable disease and their tumors haven't progressed. Now there are two types of maintenance therapies, namely continuation and switch. Now continuation, the first one, uses the first line agent as maintenance therapy, while in switch maintenance therapy we use a different agent that wasn't included in the first line therapy for maintenance. I'd like to add that pembrolizumab or gemcitabine are options for continuation maintenance therapy, whereas docetaxel is majorly for switch maintenance therapy. Now, according to the NCCN, patients with squamous non-small cell lung cancer who have responded to the first line treatment or who have stable disease may be treated with continuation maintenance, which includes pembrolizumab, marketed as Keytruda, or gemcitabine, which is marketed as Gemza, if any of these agents have been given as first line. I would just like to re-emphasize that switch maintenance is usually with docetaxel, marketed as Taxotere, and the NCCN guidelines recently removed the recommendation for erlotinib as switch maintenance, and subsequent therapy for these patients with squamous NSCLC as overall survival and quality of life were not improved when erlotinib was used. Just as a by the way, let's move to the next question, please. Mr. TWP, a 38-year-old male patient suffering from Crohn's disease, type 2 diabetes mellitus, and hypertension, recently received communication that his 69-year-old dad was diagnosed with rectal cancer. TWP is an obese cigarette smoker. He smokes around 1.5 packs on a daily basis, and apart from eating a lot of beef or steak, he spends most of his evenings viewing TV in his living room. He leads a sedentary lifestyle, and he seeks to know from your medical oncologist his risk of or for colorectal cancer. So my question to you is, which of the actions or steps listed below would you recommend he takes in order to modify his risk factors with the aim of reducing the colorectal cancer risk in his case? Would you recommend he gets his hypertension under control? Would you recommend he views his TV in the morning instead of in the evening? Or would you recommend he adopts a high fiber, low fat diet? Or would you recommend he stops smoking the moment he attains the age of 50 years? I'll give you 10 seconds to choose the correct answer. In my opinion, I would recommend he adopts a high fiber, low fat diet. Now, studies support the conclusion that adherence to a healthy lifestyle, such as healthy weight, physical activity, non-smoking, limited alcohol consumption, and even healthy diet, can reduce the risks of colorectal cancer. I would also like to add that red or processed meats and high fat consumption can increase the risks of cancer in general, and a diet that is high in fiber or low in fat can significantly reduce the risk of colorectal cancer. Now, switching his TV viewership from evening to morning won't help. It still encourages a sedentary lifestyle, so it makes no sense at all. And getting his hypertension under control will help him with cardiovascular risk, but not with colorectal cancer. So that wouldn't be the best way out. And then quitting smoking will reduce the risks of colorectal cancer, but Mr. TWP needs to do it now and not wait until he is 50 years old. So that makes answer D wrong. Then I would like to add that maintaining a healthy lifestyle can reduce the risk of colorectal cancer. Now, some data suggests that daily consumption of aspirin or NSAID can reduce the risk of colorectal cancer, just for your information. Let's move to the next question, please. And it reads, TNT, a 66-year-old patient with non-small cell lung cancer, presents to your oncology clinic with complaints of heartburn accompanied by stomach pains. He denies any black or blood-stained stool. He is neither nauseated and doesn't vomit. He is currently receiving erlotinib therapy. He experiences stable pain, which he controls with NSAIDs along with morphine. So my question to you is, which of the courses of action listed below would be the most appropriate for Mr. TNT's suspected NSAID-induced gastritis, which could be behind this pain? Would it be appropriate to continue NSAID therapy and instead opt to start omeprazole? Would it be advisable to continue NSAID therapy and start ranitidine? Or would you advise them to stop NSAID and start aluminum hydroxide or magnesium hydroxide as antacids? Or would you recommend they stop NSAID and start cimetidine? I'll give you 10 seconds to choose the correct answer. C would be the best answer, and I'll try and explain why. Now, stopping NSAID will be the most appropriate initial step in Mr. T&T's case. Now, proton pump inhibitors and the H2 receptor blockers will be more effective than antacids for gastritis, but they will potentially decrease the pH-dependent absorption of erlotinib. Remember, the patient is being treated with erlotinib, and if the absorption is reduced, that could lead to subtherapeutic erlotinib levels and even treatment failure by extension. Now, I would like to add that oral antacids don't significantly alter gastric pH, so their interaction with the erlotinib will be less likely to affect the absorption. Now, some data claims that separating the H2 receptor blockers from erlotinib could minimize this interaction. I would also like to add that cimetidine, which is marketed as Tagamet, though it's fading away from our market, could be administered in this fashion, but it isn't desirable, and that is due to a drug-drug interaction. Remember, it is a CYP3A4 inhibitor, and CYP3A4 is required for erlotinib metabolism, and if we co-administered cimetidine with the erlotinib, there would be a possibility of erlotinib toxicity or accumulation in this particular patient's case. So I would not opt for it. C would be the best bet in this particular question. Let's move to the next one, please. And it reads, following a pelvic or abdominal CT scan, HPJ, who had a nephrectomy done 5 years ago for renal cell carcinoma, what we abbreviate as RCC, is found to have lymphadenopathy, and HPJ's labs are within normal limits, and his Karnofsky's performance status is 80%. So my question to you is, how would you classify HPJ's prognosis basing on the Memorial Sloan Kettering Cancer Center criteria, what we abbreviate as MSKCC criteria? Is it true that not enough information is available to assess it, or is it true that he has an intermediate risk, or does he have a low risk or good prognosis, or is it a question of poor prognosis, poor risk? I'll give you 10 seconds to choose the correct answer. I would classify HPJ low risk or good prognosis. Now, the MSKCC score is the most commonly used prognostic factor, and it was originally derived from studying prognostic factors in approximately 463 patients with metastatic renal cell carcinoma, what we abbreviate as RCC, who were enrolled in clinical trials and treated with interferon alpha. And it focuses on 5 variables, which are time from diagnosis to systemic treatment of less than 1 year. Second is the Karnofsky's performance score of 80%. Then there is also serum lactate dehydrogenase greater than 1.5 times the upper limit of normal. And there is corrected serum calcium greater than the upper limit of normal, and serum HB less than the lower limit of normal. I'd like to add that patients with none of these factors are considered low risk, and those with 1 to 2 factors are considered intermediate risk, and those with 3 or more of these factors present can be considered poor risk. Now, based on the information provided, HPJ has no risk factors and is considered low risk, and good prognosis. And I would like to add that his time from diagnosis to systemic treatment is over 1 year. His Karnofsky's performance status is 80%, and his labs are within normal limits. I would like to reiterate that the MSKCC score is widely used to predict survival and to guide systemic treatment in metastatic renal cell carcinoma RCC patients. And the most common histologic subtype of RCC, just for your information, is the clear cell type, which originates from the proximal tubule, and most commonly it shows what we call a 3p deletion. Let's move to the next question, please. And it reads, historically, renal cell carcinoma RCC has been a very resistant tumor in relation to hormone therapy or chemotherapy. Its pathophysiology is currently better understood, and this has resulted in the development of a number of targeted therapies to treat renal cell carcinoma RCC. So my question to you is, which of the tumor suppressor genes inactivation is implicated in the majority of clear cell renal cell carcinoma cases or pathophysiology? Is it BHD, VHL, EGFR, or MET? I'll give you 10 seconds to choose the correct answer. VHL it is. Now that VHL is an abbreviation for von Hippel-Lindau. So the von Hippel-Lindau gene has been implicated in clear cell renal cell carcinoma. Now cell histology accounts for 70% of RCC, and the VHL gene inactivation is responsible for at least 60% of clear cell RCC, which eventually leads to increased angiogenesis and tumor growth. The MET gene abnormality is implicated in papillary RCC, while the BDH gene abnormality is implicated in chromophore or oncocytoma RCC. Then the EGFR gene abnormality is implicated in lung or breast cancer patients. So those others do not apply to this particular case. Now, just like to add that the VHL gene inactivation predisposes patients to clear cell RCC, and VHL inactivation leads to increased hypoxia inducible factor, what we call HIF activity, and subsequently increases vascular endothelial growth factor A, VEGF-A expression. Now, VEGF inhibitors such as sunitinib, sorafenib, and bevacizumab should be used to treat clear cell RCC. That's just for your information. Let's move to the next question. And it reads, which of the antiemetic regimens listed below is recommended prior to CHOP, cyclophosphamide, doxorubicin, vincristine, and prednisone chemotherapy? Is it metoclopramide 30 milligrams orally? Is it dexamethasone 20 milligrams orally? Is it ondansetron 24 milligrams orally? Or is it prochlorperazine 10 milligrams orally? I'll give you 10 seconds to choose the correct answer. So ondansetron 24 milligrams orally it is. Now, since this regimen contains prednisone, the addition of dexamethasone alongside ondansetron isn't necessary in my opinion. Both are steroids, for your information. Now, if the patient didn't take their prednisone before receiving the chemotherapy, the administration of dexamethasone alongside ondansetron should be given. And I would like to add that prochlorperazine and metoclopramide and or dexamethasone alone aren't recommended as first-line agents for prevention of chemotherapy-induced nausea and emesis. Let's move to the next question, please. And it reads, HOM is a middle-aged patient with renal cell carcinoma who was initially receiving temsirolimus 20 milligrams IV once weekly. After 8 weeks of therapy, his blood glucose concentrations exceed 330 milligrams per deciliter on several occasions, and several interventions to control the high serum glucose concentrations have been futile and unsuccessful. His temsirolimus was put on hold by the oncology team. His blood glucose levels have now normalized, and the oncologist would like to restart temsirolimus. So my question to you is, which of the doses listed below would be the most appropriate temsirolimus dose to restart HOM on? Would it be 20 milligrams IV once every 2 weeks? Or would it be 15 milligrams IV once every week? Or would it be 25 milligrams IV every week? Or would it be 25 milligrams IV every 2 weeks? I'll give you 10 seconds to choose the correct answer. So I would recommend 15 milligrams IV every week. Now, the recommended dose adjustment for temsirolimus in the setting of CTCAE grade 3 or greater adverse events is to hold until toxicities have resolved to grade 2 or less. Now, the temsirolimus should be restarted with the dose reduced by 5 milligrams per week to a dose no lower than 15 milligrams weekly. It's clearly articulated in the guidelines. Now, because the patient was receiving 20 milligrams per week, the next dose adjustment should clearly be 15 milligrams weekly. Now, extending the dosing interval longer than 1 week, thereby lowering the average weekly dose, isn't recommended according to the guidelines. I would like to add that temsirolimus should be withheld for absolute neutrophil counts below 1000 per mm³, or when the platelets are below 75,000 per mm³, or in cases of CTCAE grade 3 or greater adverse reactions. Remember that. Now, once toxicities have resolved to grade 2 or less, temsirolimus may be restarted with the dose reduced, as I said earlier, by 5 milligrams per week to doses no lower than 15 milligrams per week. Now, just like to caution you that temsirolimus is a CYP3A4 substrate, and therefore strong CYP3A4 inducers or inhibitors affect its clearance. Now, appropriate dose adjustments for temsirolimus should therefore be considered when administering it concomitantly with any CYP3A4 inducers or inhibitors. Be cautious and do drug-drug interaction checks when you have to co-administer it with those inducers or inhibitors to avoid either toxicity or having treatment failure due to subtherapeutic serum levels. Let's move to the next question, please. And it reads, GPY, a middle-aged patient who has failed multiple therapies for metastatic renal cell carcinoma, will now be treated with temsirolimus after the oncology team discussed his case. My question to you is, which of the adverse effects listed below is the most commonly experienced by patients receiving temsirolimus? Is it hypertension and proteinuria? Is it diarrhea and heart and hand-foot syndrome? Or is it peripheral edema and hypercholesterolemia? Or is it capillary leak syndrome and hypotension? I'll give you 10 seconds to choose the correct answer. C it is. Now, peripheral edema and hypercholesterolemia are common side effects of temsirolimus therapy, and capillary leak syndrome and hypotension are significant concerns of interleukin-2 therapy. Doesn't apply to this temsirolimus. Then diarrhea is also commonly associated with temsirolimus, but not hand-foot syndrome, so that makes option B wrong. Then I would like to add that hypertension and proteinuria most commonly occur with bevacizumab therapy, not with temsirolimus. And I would like to add that hyperglycemia, hyperlipidemia, peripheral edema, and diarrhea are all common side effects associated with temsirolimus therapy. And then temsirolimus induced hypercholesterolemia and hyperglycemia are caused by inhibition of mammalian targets of rapamycin, what we call mTOR, regulated metabolism of both glucose and cholesterol. I'll repeat that. Temsirolimus induced hypercholesterolemia and hyperglycemia are caused by inhibition of mTOR regulated metabolism of glucose and cholesterol. Let's move to the next question, please. And it reads, which of the side effects listed below isn't observed in nilotinib use? Nilotinib is marketed as Tasigna. Is it pancreatitis and elevated serum lipase? Is it nephrotoxicity? Is it QT prolongation? Or is it fluid retention? I'll give you 10 seconds to choose the correct answer. Nephrotoxicity it is. Now, it's quoted widely in literature that nilotinib has been known to cause fluid retention, QT prolongation, pancreatitis, and even hepatotoxicity, but it doesn't cause nephrotoxicity at all. So that makes answer B the correct answer. Let's move to the next slide, please. And the question reads, Mr. ZAJ, a 67-year-old man, suffers from small cell lung cancer, and he receives cisplatin at a dose of 75 milligrams per meter squared on day 1. Then he also receives etoposide at a dose of 100 milligrams per meter squared on days 1, 2, and 3. Now, after cycles 2 and 3, Mr. ZAJ returns to the oncology clinic for treatment of breakthrough nausea and vomiting. After the third cycle, ZAJ met his oncology nurse at the supermarket, and after speaking to the nurse, Mr. ZAJ began vomiting. So my question to you is, what type of vomiting is Mr. ZAJ experiencing in this clinical scenario? Is it delayed emesis, anticipatory emesis, acute emesis, or breakthrough emesis? I'll give you 10 seconds to choose the correct answer. This is a clear case of anticipatory emesis. Now, anticipatory vomiting is a learned response from a history of poor emesis control during administration or treatment with chemotherapy. Now, if a patient has a repeated emesis episode after repeated chemotherapy cycles, the patient may be at a risk for anticipatory vomiting. Now, the patient may see someone or something or experience a certain smell and have vomiting. Now, in the above case, he sees his nurse and immediately has vomiting because she is associated with his chemotherapy administration and then having emesis. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I'd like to urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best, the very, very best is yet to come. And I would like to thank you very much for viewing this video and for listening to me. And I sincerely appreciate your partnership, your continued support, and your kind collaboration. I look forward to interacting with you in the next video in our MCQ series. Thank you very much.